Thank you, Tony, for the opportunity. While I was sitting in the back there, I looked around and I saw that there's definitely some clients in the audience. So I hope I can keep your focus and keep your attention to the talk. I'll try to be brief. Just a disclaimer. I'm definitely not a specialist in the field. I see Silas Springers in the audience. There are some other specialists, so I'm not a specialist in this field. I'm just a general pediatrician that was confronted with a problem and we did something about it. So that's the perspective I'm coming from. If you want to see the golden standard, you must talk to people like Silla and Estelle Lawrence, who did a protocol for the metro. So I'm giving the district perspective. So overview, just going to give you the context, our challenges, interventions, then what we did, and our algorithm that we used. So Paul is situated here in the Drakensberg. We've got quite a unique situation where we are in the Cape Winelands, but the rest of our GSA is in the West Coast. So we have different district managers in the Cape Winelands and also on the West Coast. So different teams to work with. So it's not one person that deals with Department of Education. We must deal with quite a few different peoples across the different departments. So just to give some stats over the last about 7 years, you can see from 2010, we had about 100 contacts. This is POPD, pediatric outpatient visits to our Paul Hospital. This is not the whole GSA, just for Paul Hospital. And I just put in asthma for comparison. And it's not that the incidence of asthma is going down. We just really had effort to get our asthma kids back into primary care. And that's why you see the asthma contacts coming down. And it's interesting because asthma was always the most frequent visit to our clinics. And you can see 2016 is a benchmark year where we saw more children with ADHD this year than we saw with kids with asthma, which is quite profound. So we were faced with a problem. So our challenges is in our GSA, there's quite a lot of poverty, poor psychosocial circumstances, violence, alcohol abuse at home, and that leads to quite poor parenting skills and supervision, lots of single parent households, high incidence of behavioral problems and comorbidities, and this really gives a challenge to diagnosing ADHD because you have all these behavioral problems coming in as well. We have challenges with our school-based support teams, which are not functioning very well at some of the areas. We have human resource limitations, school psychologists, clinical psychologists, school nurses, occupational therapists, mental health nurses. They're all limited in our area. We have no school doctors like the Metro, and we are the same as the rest of the country. And there's really a poor understanding of ADHD in the community and the schools, and for that reason we get a lot of inappropriate referrals, and we get parents phoning the OPD, my child's got ADHD, can I send him? The parents phone us directly, and lots of education that needs to happen in that regards. And then there's poor integration between all the services and the referral pathways, and also problems with the dispensing of drugs at the pharmacies. So just to summarize, we have a high burden of disease, we have a lot of poverty and violence and neglect, and within this, poor integration between the services, and it's really silos, everyone working in their own silos. So that was the problem we were faced with. So we said no more. So we had a meeting with all the role players in the area. We didn't have a mental health forum as formal as that. It was more an informal meeting. And we developed a package of care for children with ADHD for our area, which included a protocol for the management of ADHD, pathways for new referrals, criteria for new referrals, guidelines for first visit, guidelines on routine care, contraindications for medicine and for adverse effects. Also, a criteria for referral back into primary care level, and also criteria for referral to tertiary center, when to discontinue the treatment, and we also have used a modified Connors vulnerable scale that we use, and also we provide information for the parents and the teachers. But other interventions, we also did information sessions at some of the schools with the highest prevalence. And then maybe one of the most important interventions was we had structured feedback to all the teachers that referred children to us. We give them feedback. So I'm just going to go through our algorithm. So step one, and it's different than in the metro. It's much more simpler because of our situation. And we don't have all the resources that the metro has. So step one is the identification of a child at risk, and that's done mostly by the teachers and the parents. Step two is then referral for evaluation and non-medical interventions. So they will refer to the school-based support teams, the teachers for the learners with special educational needs, the school psychologist, occupational therapist if it's available, and they also go via the clinic to screen for hearing problems, vision problems, or other general medical problems that can also look like ADHD. And then step three, if these interventions, non-medical treatment failed, then the children will be referred for further evaluation, usually by the school-based support teams, if it's available, or the school psychologist, and they will, and if there's an occupational therapist report. Then step five would be the district pediatrician, and this function is in the metro is done by a school doctor, which we don't have. And also there's assist in the adults. They have the psychiatric or the mental health nurse that can help with this function. We also don't have that. So then the step six will be to bring them back into reevaluate the treatment, and then the route out will be either referral to tertiary care if it's a complex case. That will be to the neurodevelopmental specialist or child psychiatrist, and then and the other way out will be referral back to primary care, and we've got good guidelines for that. So, thank you.